I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Hi, Sally. Lovely to see you in this sunny half-term.
Goodness gracious, it has been sweltering, hasn't it? Oh my word. But yeah, really nice to see you. Good to see that you're not too sunburnt. So you've been sensible, Jam. I've been inside the whole time, so there's not a whiff of sunshine for me. But yeah, looking after yourself.
Doing my best. I've realised that fans really don't work. This is my kind of main philosophical summary from the last few days. They just move hot air around. But anyway, but I've spelt lots of money on them. I've broken a couple. In a way, this brings us kind of onto what we're talking about today, because actually when it is this hot and you're kind of heading towards summer, infection isn't something that you naturally think about, right? Because infection is something that we associate more with different times of years. But today we just want to talk broadly about what is a huge topic, actually, infection in myeloma. If we sort of take a step back, so when you're thinking about infection in myeloma, Sally, how do you break it down? And I think that will give us a nice way to sort of lead into this episode.
It's a really good lead in, isn't it? But I guess for those observant listeners, you might notice I'm a bit croaky, which I think speaks to the fact that I've had an infection over the last week, slowly recovering. Thank you. It's to my delightful how old's my son? 7-year-old son. I always get his age wrong. How bad is that? So I think it just goes to show that infections can occur all sorts of, all times of year, although they are certainly more common in the winter months. So the way that you can approach, thinking about infection, and that we do from a medical perspective, is there anything in particular about that person that makes them more vulnerable to infection? So, for example, do they have any lung problems, which means that they may be harbouring low-level infections more long-term? Is there anything about the treatment which may mean that they're more at risk of infection? So we've spoken on previous podcasts about some drugs, particularly the newer drugs, which can make you more vulnerable. Is it something to do with the time of year, or something going round, like we're in the middle of the flu circulating in the community, or norovirus that could make people more vulnerable to infection? And then lastly, thinking about the disease itself, because we know when myeloma is more active, particularly when you're newly diagnosed and it hasn't been treated, or when you're relapsing, then there's an increased vulnerability to infection then as well. So you can broadly sort of break it down into those categories. And if you make those assessments in your head when you're living with this condition, or from a medical perspective, from a doctor's perspective, you can see how infection and the risk of infection can be very dynamic. It can change with time, which is why it's often quite a hard issue to sort of like grapple with. There's no certainty about I am always at increased risk, or I am definitely not at risk now. So that's how I approach it.
Really nice summary there, Sal. So if we start with the disease itself, there are unfortunately a number of factors relating to myeloma that increase the risk of getting an infection. Clearly, one of those key things is how myeloma itself affects the immune system, and it affects it in many subtle ways relating to the way in which certain types of cell function, our T cells, part of the important immune system that we've talked about in relation to immunotherapy. And this may increase susceptibility to certain types of infection. And we've all met patients who the first time actually we've diagnosed they've had myeloma is actually because they've come into hospital with a very serious infection, sometimes out of the blue. So the inherent nature of those plasma cells proliferating can stop you making antibodies to other types of infection, which lower your ability to withstand it. So the disease itself. So unfortunately, when we meet people for the first time, there are unfortunately a group of people that do succumb very early from infection before you've had a chance to control the disease, which can help kind of reboot some of your immune system. But there are also those other factors as well. So bone disease can increase the chance of infection. Now, that might not make sense initially, but for example, if you have bone disease in your ribs, you've got painful ribs, you can't take a deep breath. And being able to clear your chest and take deep breaths is one of the ways in which you stop getting chest infections. So if you're taking shallower breaths, you can't clear what's in your chest, you're at an increased risk of pneumonia, for example. If you have other sorts of pain as well, you're more sedentary, you're lying down more. Again, chest infections become much more common. So it's not just the effect of the immune system, it's the effect of the disease as well.
I definitely support that. And the other thing to consider as well is kidney failure. Kidney failure in people with myeloma, sometimes it can creep up on somebody. They don't know it's occurring. Sometimes it can feel, it happens quite suddenly, but your kidney's not working properly as well can also have an impact on that widespread sort of overall immune health. And so it does become very much interrelated. And it can sometimes feel like it's this sort of downward spiral until you get on top of it. That's, I think, what sometimes it's not hard to understand, but it's important to understand is, yes, the treatment in the short term might increase your risk of infection, but in the long term, it decreases it compared to if you didn't have treatment. So, the disease can cause all sorts of problems, all sorts of infections. I mean, definitely we see a lot of chest infections, don't we, Jam? But also, I guess we see all sorts of other infections. Skin infections can occur, line infections, definitely infections when you're having a transplant, which we can speak about that in a short while, but because of the way that affects the tummy and the way infections then enter into the body. So eye infections can be problematic, as well as the common coughs and colds, which circulate and go round. And something which I think is quite interesting to say, and people often say to me in clinic, particularly those who are living, as we are actually, with younger children or with partners, so seasonal coughs and colds come round. But when your myeloma is under control, sometimes people view that as a test. If their partner gets a cold, how bad are they going to get it? And they can often be quite heartening when they say, actually, I got that sniffle, but I shook it off quite easily. I actually wasn't sometimes as poorly as the other person in the household. So infections do come and go. They can relate to the condition, but importantly, the treatments can change that risk of infection.
Indeed. And it's almost like you treat the condition and it restores after a certain length of time, what we call immune competence. It's a very simple test, isn't it? It's like everyone in the family got a little bit of something for a couple of days. And you know what? I got it as well, but for exactly the same length of time. And absolutely, that can fill you with confidence because, of course, the way everyone thinks of infection, every single person in the world thinks of infection now has been changed since the COVID-19 pandemic. And things that we thought about then have really impacted what people ask us now in the clinic, still using the term. Should I be shielding? Should I avoid X, Y, and Z? Can I go to the theatre? Because, of course, so much about avoiding and minimizing infection can be associated with big and significant impacts on quality of life.
And that's where there is a tipping point, isn't there, in terms of wanting to keep oneself free from infection and therefore as well as possible. But if you think that going out there and living your life is going to put you at risk of infection, you may be inclined to step away from doing certain things. And that's where I think that appreciation of the fact that your infection risk changes is so important, because hopefully that means that when the myeloma is under control, people living with myeloma can have a degree of confidence that, they can go to the theatre, they can go shopping in the supermarket, they can get on an aeroplane to go on holiday, knowing that, of course, that there might be infections circulating. Well, they're more likely to circulate in those environments, sure. But if they come your way, you're also very likely to get over them, just like the next person. And so it's that tipping point of balance of quality of life and risk. And everyone's at a different point in that scale. Some people, even though I know I certainly encourage people to get out there and live your life, you're doing really well, everything's under control, but there may still be a degree of hesitancy, which we totally understand. And it's just a case of knowing how far you want to push things, really.
So treatment can increase the risk of infection. And we've said that myeloma can increase the risk of infection and people are higher risk. So you're starting from a situation where you're at risk, and then you have to give treatment to try and control the myeloma. But over time, in different situations, and it's different in everyone, there becomes a tipping point where your immune system can improve and help and increase your sort of shield, your ability to stop you getting problems. But I mean, very broadly speaking, how does treatment increase your risk of infection? And then, we can just chat a little bit about the different types of treatments, because they all actually have different impacts on your ability to get infections.
So I'm going to use actually one treatment as an example, if that's okay. And this is lenalidomide, because it's a drug which is many people have been exposed to and many people are on, and it provides a really nice example. Lenalidomide, we know, is one of the many drugs that we can use to control myeloma. When the myeloma is at its most active, the healthy immune system has become somewhat defunct. It's not working properly. Instead of making healthy antibodies, which are types of protein that circulate to fight infection, the the myeloma mucks that all up and makes these unhelpful antibodies, or what we call the paraprotein or the light chains, which can't fight infection. But in doing so, they stop the good antibodies from being made. So you get the useless proteins being made at the expense of the useful antibodies. And so a treatment like lenalidomide might control the myeloma by reducing those abnormal or useless proteins, the paraproteins. And in doing so, it allows the healthy antibodies to increase. You suppress the bad ones, and the goodies, to some extent, can kind of come through. It really is almost like the goodie and baddie situation, actually. So the healthy antibodies can then grow through and help the body to recover if they are exposed to an infective, attack of some sort. But lenalidomide, for example, if you were to accidentally take too much of it or be prescribed too much that doesn't suit your body, it can also lower the other blood cells. An example of that might be your neutrophils, which are really important for fighting bacterial infection. And so you can overdo it, and that can then increase your risk of infection. So not related to the antibody side of thing, but related to other cells which can fight infection. And so there's always that tipping point whereby at the beginning, your myeloma is active, the immune system's not working. The treatment, when it's finessed properly, used properly, and it works, should allow the healthy antibodies to grow and the defunct proteins to decrease, and therefore reignite your natural immune system. But if the treatment is too strong or causes toxicities, it can, in and of itself, increase the risk of infection because the other cells in the body, which are important to fight infection, might also be affected. So it is complicated. It's a lot to understand, and that's why we do spend a lot of time talking about blood counts. And I think as people live with myeloma for longer, they too become the experts in understanding, okay, well, this one's all right and that one's okay. And in this situation, that means X, Y, or Z.
It's a really delicate balancing act. And, what I'd say to people as they, go to their clinic appointments or they speak to their doctors, whatever stage of the disease you're at, think about infection as a topic that maybe you want to cover if you're not sure as you go into the clinic room, and ask, I don't feel quite right. And speak to the doctor, and they'll ask you sort of standard questions. Do you have a fever? Have you felt like congested, or what we say coryzally, or like you've had a cold? They might examine your chest if you've got some chest symptoms, or think about other things. Do you have urinary symptoms? And then, of course, we send samples. We look for inflammation in the blood, and then we look for infection, whether it be in blood bottles if you have a high fever, or send in urine to the lab, or very commonly doing these swabs called, viral swabs, looking for COVID and other viruses, which can be very common in myeloma patients, and also sometimes very difficult to clear. And they can really have an impact for a long period of time. I know this is maybe a very basic point, but sort of antibiotics like, penicillin and stuff like that, they don't work there for these viruses. And antiviral treatments, although there are some available, are not like antibiotics. And in lots of situations, they don't really help clear the viral infection. You just have to wait, and over time it improves. Now, that's not an absolute rule, but I think understanding how you talk to your doctor about those infectious symptoms and making sure the right tests are done, and really crucially, anything that can be treated should be treated early, can make a big difference.
I'm with you all the way there. Flag things up. Don't be scared about doing so. It's never, you're never overdoing it if you're concerned that you're poorly and something is potentially brewing. It's also just something to really quickly explore, Jam, is a lot of our patients are actually taking regular antibiotics, cotrimoxazole. They're taking regular antivirals in the form of acyclovir. So why are they still at risk of infection? Can you just talk me through that and what that means?
It's a great question, Sally. So prevention, of course, is what we would like to do. We would like to prevent infections from becoming a problem. And with lots of myeloma treatments, those two things that you mentioned are important parts of the prevention sort of armamentarium. Acyclovir is a very good drug for stopping shingles. It's taken, 2 to 3 times a day, and there's specific treatments, especially drugs like bortezomib and carfilzomib, that increase the risk of getting reactivation of this virus that causes shingles. And, most of us have had shingles. I've had shingles. It's pretty horrible, and we want to prevent it where we can. So that's the reason to have acyclovir. Cotrimoxazole is an antibiotic that's given 3 times a week, which is there to prevent a specific type of quite rare chest infection that we don't see that often, but when it happens, it's called pneumocystis. It can be, very significant. So if we can prevent it, then we should. Not everyone needs it, to be fair, and I use it selectively. And it also actually has some antibacterial effect as well. I think it does help people not get other infections. So it is quite useful, but it can reduce your blood counts and cause really quite a nasty rash as well, which I know a number of our listeners will have had, and we do see it quite a lot. So those two are important preventative measures. In some situations, we give people a drug called fluconazole or something similar, which is a type of antifungal agent, because our old friend Dex, our steroids or prednisolone, can increase the risk of fungal infections. But I have to say, I think it's very rare for myeloma patients to get significant fungal infections. And I tend not to use it, Sally. I don't know what you do in your practice. And are there any other preventative antibiotics that you sometimes consider using?
Yeah, there was a really great study actually run by colleagues and friends here in the UK called the TEAM study, which looked at using just antibiotics at the very beginning of someone being diagnosed with myeloma, a particular antibiotic called levofloxacin. And that showed some really promising results. It basically showed that if you give some patients this antibiotic when they're newly diagnosed versus not giving them the antibiotic, the patients who had the antibiotic fared better. They got fewer infections, and the infections they got weren't quite so serious. However, all treatments come with downsides. This particular antibiotic can affect the tummy sometimes. And so actually prescribing it, you have to consider it carefully. And actually, I know in some centres, there might be limitations to prescribing it because people are aware about getting a tummy bug if you're on an antibiotic. So this is never black and white, and local practices do differ, and they will differ wherever you're being treated. Something else that's, I think, really important just to pull out is we've spoken about, you've mentioned a few drugs there, all got terribly long names, haven't they? Cotrimoxazole, levofloxacin, acyclovir, fluconazole. They're all different ways of fighting different types of infection. But it's really important to say there are loads of different types of antibiotics out there and lots of different antivirals out there to target particular infections, which is why even if you are on all 4 of those drugs I've just listed to prevent fungal infections, bacterial infections, viral infections, you may still pick something up because it may be that those treatments do not cover a bug that's circulating that you've been exposed to. And that's why this is not black and white, and why talking to a doctor about it's incredibly important. Thank you for listening to the Myeloma Minutes podcast, proudly partnering with Myeloma UK. For more credible myeloma-related material and support, please visit the Myeloma website at myeloma.org.uk. That's myeloma.org.uk. Or call the info line on 0800 980 3332, which you can find in this episode's description.
Sally, you mentioned that drug levofloxacin that in some situations people will use for sort of 3 months at the start of a new treatment. And sometimes people use that even if people are having maybe a second or third treatment. We now have, more intensive drug combinations that we've talked about, especially in our older patients. Some of them are getting 4 drug combinations now. And in certain situations, this is really the right thing. I have to say, I haven't always been a fan of using levofloxacin for those 12 weeks because of a number of reasons, the potential side effects, potential impact on what infections people might get later on down the line. It's very interesting if you speak to our amazing colleagues who are experts in infectious diseases and microbiology, there are downsides to this approach. But what I was going to say is for older patients now who are having a 4-drug combination, I use it because I feel that with these powerful 4-drug combinations, infection is quite a strong signal when you are using 4 drugs together. And I think this is an intervention that, can have a significant impact. And then after, they're more settled on the treatment, the myeloma is more under control. And as you've said, some of your immune competence, in certain areas has been sort of reignited, then you stop the treatment.
Everyone's got a somewhat different approach to this, but I don't disagree, Jam, to be honest with you. And I think the key thing is, just having a chat about it in clinic and seeing what preferences are. The other thing I think is really important for us to really briefly touch upon is, as we've just been saying, really the pros and cons of having antibiotics, because I think it's really the common understanding of antibiotics is you should take them when you need them and you shouldn't take them long term. And yet what we're saying is in some situations, you might be on antibiotics, for example, for a really long time in the case of cotrimoxazole, or levofloxacin for 12 weeks, even if you don't have infection. And that's somewhat different from what we hear about antibiotic prescribing and resistance. So yes, there are downsides. You have to prescribe these treatments carefully and with thought. But what we don't ever want to happen is for our treatment to make someone so poorly that they are in hospital for a long period of time, or sometimes actually can have an infection which really threatens their life, where we think we could have done something about that to prevent that from happening. And so that's kind of the logic with which I think we approach these situations, isn't it?
It is. And unfortunately, Sally, we've all lost patients to infection. It happens all the time. Still, you don't forget these cases as a practicing hematologist. So, yeah, we're liberal with our antibiotics, but we do it for a good reason. And of course, there is an understanding that, you have to prevent antibiotic resistance and all these problems. But we do know for our patients, if you get in early, I think it does make a difference. If you can stop people having to come into hospital, stopping sepsis, these things are so important. Sal, if we stick with the preventative theme, we've mentioned it on our bispecific antibodies podcast, but increasingly now for these newer, more powerful immunotherapies, this concoction called IVIG, intravenous immunoglobulin, is a crucial preventative measure, but it's not an antibiotic.
Exactly. So it's not an antibiotic. So just for a recap, for those of you who may not have listened to those previous podcasts, or for those who did, and it's useful to have a reminder, the bispecific antibodies, a particular group of them, they're proteins which go into the body and kill the myeloma through identifying the myeloma cell because it's got a protein on the outside called an antigen. But there's two different names for a type of treatment, the bispecific antibody treatment, that latches onto an antigen, the protein, which is also on healthy immune cells. So when you have that treatment, yes, you're killing the myeloma, but you're also going to kill healthy immune cells. And that's really important because then your immune system is really, it's kind of basically gone to sleep. To enable your body to function properly and have a chance of responding to an infective problem, we infuse proteins into that person's body, which act as antibodies to hopefully prevent infection or lower the risk of infection. And that's called intravenous immunoglobulin. So immunoglobulin is another way of describing antibodies which come from somebody else. They're donated and then given to that person, the myeloma patient, to help their immune system remain nice and strong. And that's been proven time and time again to lower the risk of infection. And if you do get infection, it's far less serious.
This is a blood product. So these are antibodies that have been made by other people. So you're literally, borrowing, well, technically not borrowing, you're keeping them, these antibodies that other immune systems have made, and you are given those every 4 to 6 weeks while you are on specific types of myeloma treatment, including bispecific antibodies. And importantly, you probably will need to continue them after you come off them, say if you don't get on with it or you've progressed, because the immune system will remain low for some time. It's an absolutely crucial part of the prevention armamentarium. If we just stay for another couple of minutes on prevention, what else, apart from specific behaviors that we kind of touched on in terms of obvious things like trying to avoid people who have infection, or you're worried that you could be in a closed environment which might increase the risk, are there any other medications or support things that you recommend to people to try and prevent them getting infection? Because, even for those of us that don't have myeloma or other illnesses, we're continually being sold stuff for our immune system. Take 35 tablets of vitamin C today and you're going to be absolutely fine, forever. I mean, are there some pragmatic and sensible things that you recommend?
Great question. And my answer to that is kind of twofold. One is just so obvious. You'll be like, yeah, of course we know this. Sleep is incredibly important. Now, when you're pumped full of steroids, that can really impact on your sleep. So I know that can be difficult, but sleep really does help the body regenerate, helps you rest, helps you recover. That's why when we're poorly, we go to bed if you're feeling particularly rotten. So definitely trying to get a good night's sleep where you can, listening to your body. And if you're feeling under the weather, not pushing it and seeking medical advice is really important. Good nutrition is incredibly important. All those really sensible things that you can do. But something else people are often advised to do, I hope they are in the majority of centres, is if you feel poorly, don't just wait. Seek attention. You'll have a phone number. Often people are given a card with a phone number, a 24-hour helpline on it, for example. Or someone to contact out of hours if they run into trouble. Don't just think, I'll wait till the morning, particularly if your temperature's gone up. And that brings me on to my last point, is people are often advised to monitor their temperature if they're feeling poorly. And, we tend to say that if your temperature hits 38 degrees Celsius, that's when you need to actually think there might be something going on here. I might need some help. I need to speak to hospital. I need to speak to my specialist. And they can assess me, see if I need antibiotics, see if I've got a virus. So, before anything happens, basic stuff, good sleep, good food, avoiding people who are obviously full of coughs and colds where possible. And then if in the event of feeling unwell and particularly getting a temperature, seeking medical advice, that would be, my obvious go-tos. What about you, Jam? Is there anything I've forgotten there?
I'm not in the 35 tablets of vitamin C a day.
No.
I mean, there's all the normal and important health style stuff of trying to have a good diet and, important things like that. And actually, we're going to touch in much more detail on diet, sleep, and all these other topics later this year. And we're looking forward to sharing those episodes with us. I think staying mobile is really, really important, and moving. Coming back to the point I made about being able to clear your chest and take a deep breath. Exercise has been shown to be a huge benefit to preventing from getting infection. It seems to have very interesting effects on these T cells, these immune cells that we have. And it makes a massive difference. And certainly, just speaking personally, it's something that I lean on a lot to try and sort of give me robustness against infection. Doesn't always work, but of course it's, I think a really good thing. But even if it's honestly just going for a 15-minute walk a day, I think it can make a huge difference, because when you're in pain, you've got rib lesions or you've got back pain and you're on all these medications. I mean, gosh, it's so easy just to say, forget this, Netflix and chocolate, and the Dex makes you want to eat triple chocolate. At least you have an excuse, right? I don't have an excuse. Yes. I'm just going for it. Staying mobile, just going for a walk. These things all help, because I do think that those behaviors, combined with a really good safety netting system that you mentioned with the hospital and the preventative antibiotics and education, can really provide multiple layers of protection.
Couldn't agree more, actually, Jam. Thanks for raising that. And I think that's been borne out through evidence actually in myeloma patients. We've spoken on a previous podcast about transplants, and there's been some studies looking if you can have a transplant where you sort of what we call ambulatory, which means you're kind of sleeping at home, you're up and about, but you're popping into hospital once a day to review, versus being in hospital, in a hospital bed having a transplant. Those patients are at home up about doing their thing and staying mobile and active, have fewer complications, and that means fewer infections. So this has been borne out of evidence. And like you say, understanding of exercise generally and the way it mobilizes those T cells, which are really crucial in sort of like first, noticing and tackling infection, has also been, long understood. So don't want to put pressure on you guys. Please don't go running marathons. Totally not necessary. I don't think that's what we're saying at all. But yeah, keep going, but reach out to your medical teams if needed.
Don't run a marathon unless you want to, is what I would say, Sal. We got an email from one of our listeners, and thank you for sharing. She's got smouldering myeloma. She's in her early 60s and she ran the London Marathon in something like 3 hours, 15 minutes. And
oh my God, so speedy. Unbelievable.
So do run a marathon if you want to. So I would disagree with my co-host there. Sally, you mentioned being in hospital. Now, this is something that people ask. It's quite an emotive topic. Yeah. Does being in hospital increase people's risk of getting an infection?
Yes, but there's lots of reasons for that. It's not necessarily within the walls of the hospital that there are germs flying around, which mean that you're, at massively increased risk, although people who are in hospital are poorly, and that is often with an infection. But hopefully we've certainly learned over the years what good infection control is all about. And what I mean by that, that's a medical or hospital way of describing how we limit, transmitting infections from person to person, patient to patient. So every hospital should have good protective measures in place, but nothing is 100%. It's also really important to say that when you're in bed in hospital, as I've just mentioned, you're just not doing so much. You're just not up and about, and that can increase your risk in itself. So yes, if you can get out of hospital because you're better, you've got a better chance of recovering more quickly and just staying more healthy if you can be at home. What do you think?
Really have confidence that your hospital is clean. I can't emphasize this enough. The infection control measures across the NHS, I would say, are the best in the world. And the amount of training that we all have to do regularly to show if you have a certain type of infection, what do you do? What bags do you use to dispose in? How do you clean a floor? Everything is so prescriptive. I mean, just to share a random anecdote, I mean, back when I was training, and this was only 15 odd years ago, the hospital will remain nameless, but there were still these Nightingale wards where literally beds were like 1 meter apart. And it was clear that no one really knew what they were doing from a cleaning perspective. Someone got diarrhea, norovirus on the ward. Within 48 hours, the whole thing was, I'm not going to call it a shit show, but I mean, unfortunately, that's exactly what it was. With apologies to everyone who might be eating cornflakes. But it's just not like that anymore. And especially because, of course, with haematology and the understanding that infection is even more important than some areas. But it's important in every hospital area. Your hospital is clean and people really understand infection control. And at the same time, if you see someone and, they're not in gloves or they're doing something that just doesn't seem right, call them out on it as well.
Absolutely. Really, really important. And actually, it's really important to say we too are challenged on that by our peers and we're encouraged to do so. So the nurses or the other doctors might say, hang on a minute, why aren't you wearing a mask for this person? Or you should have a gown on, So it's very much part of our day-to-day conversation is to actually say, do better. And the last thing any of us would want to do is think that we pass something on to a patient which could have been avoided because we were a bit sloppy or just didn't think about it often, actually. So couldn't agree more, Jam. However, it is still better if you can be at home to be at home, which is why people who are in hospital might be encouraged to leave when they maybe sometimes think, actually, I just want an extra day here just to feel a bit better. And they might feel there's a little bit of a nudge because we know that you're going to get better more quickly if you're at home.
But this is where technology is meeting myeloma, Sally, and it's really exciting. Wearable technologies are increasingly allowing us to understand pretty quickly whether someone might be developing an infection. And in a number of hospitals around the country and the world now, infection monitoring is done remotely and quite complex treatments are given at home. And sometimes the first clue that someone might get an infection, resting pulse has gone from 70 to 100. No fever yet, but the pulse has gone up and you're just about to get that fever. But the wearable technology, will pick that all up and then someone can come in to have those antibiotics because they're even told, please come in. I think you're going to get a fever. They turn up, literally a fever within an hour. And again, not wanting to signpost to future episodes, but we're going to do a whole episode, maybe a few actually, on, how technology is going to impact myeloma care over the coming years and how it is already disrupting and improving myeloma cares. Because actually me and Sal are just AI avatars. We're not actually really here. So, Something for the future. Although I did get one random bit of feedback saying, "Oh, we enjoy listening to your podcast." Once we worked out it wasn't AI generated, it's like, wow. Well, if you can generate banter, you can generate banter like this with AI, then I've literally got nothing left. So,
these bad jokes.
Wearables and technology for the monitoring and prevention of infection, even I think, is absolutely happening in real time, and that's really exciting.
So, Jam, something that's, which we haven't really spoken about at length, which I'm sure we'll come to, and it does deserve its own separate podcast. It's, of course, one of the ways to limit infection or decrease the risk is to have regular vaccinations. Now, many of our patients are approached about vaccinations from their GPs and they receive letters, and then they tend to come to us in clinic saying, should I have this or not? Is it a good idea? So could you just talk me through your approach to vaccinations and the recommendations as you understand them?
Most of our patients, when they come to us, will be vaccinated in terms of having their childhood vaccinations up to date, but there are specific recommendations that we try and get in before people start treatment if we can. We try and make sure that their COVID-19 vaccination is up to date. There's a pneumonia vaccine, like a 5-year pneumonia vaccine, which we try and get covered as well. As people go through treatment, it can be more difficult to implement vaccines because they don't work as well when people are on certain types of of treatment. But vaccines in themselves, Sally, they're part of your sort of acquired immunity that you have when you're stepping into a myeloma journey. So we do very much hope that our patients are fully vaccinated where possible.
Yeah, definitely. So it sort of goes along the same lines, doesn't it? If you're going to take the antiviral and the antibiotics we prescribed and maybe the antifungal, vaccinations are another part of that sort of protection. So really important part. And again, we're going to explore that in more detail because I know that patients frequently have questions about vaccinations in clinics. So watch out for that podcast that is coming soon. But I guess just one other thing we should really touch on is there are some people that we look after in clinic, bearing in mind that, myeloma is what I call indiscriminate, meaning that it can affect anyone and everyone. And that can include people who might have just, an ongoing risk of ongoing infections that we might be particularly concerned about. And I wonder if we could just spend a few minutes kind of like talking about those individuals and what our approaches are.
Thank you, Sally. So I think a good example of this is someone who might have a chronic lung disease prior to getting myeloma. We know that chest infections can be a real problem in myeloma for some of the reasons we've spoken about already. But people who have damaged their lungs, maybe because of smoking or other lung diseases, means that the ability of the lungs to do their job just isn't quite as good. Bugs can get stuck and harbour, and people can get repeated infections. So I think this is an example of some pre-myeloma patient factors that can very significantly increase the risk of infection and not only impact, the treatment that we offer, but impact prognosis as well.
Yeah, I totally agree. And it's really important that we consider that. And obviously, that we look after everybody as a whole. And because when people, come to clinic with myeloma, sometimes they come with other illnesses as well. So you mentioned lung conditions. Some people have ongoing issues, for example, with urine infections, and they're under specialists for that. Or some patients, because myeloma is more common as we get older, might have other cancers, which are also more common as we get older, and that can affect your immunity. So it is quite complex. And whilst I think we all have a very broad approach and a very broad understanding, that is often tailored to each individual patient. And again, if you are one of those people or your loved one is one of those people where you're concerned that they might have extra things that we need to think about and factor in, raise that in clinic, talk to your doctors about it so that we are sighted on that and can adapt the treatment to it.
In summary, in terms of infection, you've got those patient factors, those factors that people come to us with, their vaccination status, which gives them layers of potential protection, those previous illnesses or chronic conditions that may increase their risk of infection. Then, of course, there's the impact of the myeloma itself and also the impact of treatment. And then just the environment. What time of year is it? Is there a wave of flu going through? Is there a particularly virulent strain of COVID? And then, of course, there are the behavioural factors as well in terms of how people live and how they interact in a world where they may, pick up infections from other people. So all of those factors as an arc are key considerations when thinking about infections in myeloma patients. But Sal, just as a sort of closing point, what's the future of how we treat infection in myeloma patients? We touched on it a little bit with the wearables, but what else do you see happening? If we're doing this pod again, in 5 to 10 years' time, will we be talking about slightly different things?
Goodness, I think things will be so different, won't they, in a few years' time? And that's partly because, we've got these really amazing drugs. I mean, we've spoken about them on the podcast, particularly those bispecifics, which look like they are fantastic at controlling the myeloma and actually really good when you've just been diagnosed with myeloma, although that's not yet available. So there's these fancy new drugs which come with an increased risk of infection. But as we're using them, we're learning as time goes by how to give them differently to lower the risk of infection. So, for example, these drugs might become standard. You might get immunoglobulin next alongside them, but you might also have the drugs less frequently, which will get around the infection risk. Alongside that, the exciting treatments which are no longer breakthrough, but are yet to be available on the NHS. So yet to be standard of care in the UK, but hopefully coming soon. CAR T-cell therapy. Now that can increase your risk of infection, but it's almost like it's one shot and you're done and then you're monitored afterwards. And again, the longer you're in remission following treatment like that, hopefully your infection risk changes and actually decreases with time, despite, you might need things like immunoglobulin in the short period. But then as as you then live with your myeloma and myeloma-free, hopefully, the risk of an infection is minimised. So I think the treatments are going to change a lot. How we give them is going to change a lot. And therefore, we'll be able to adapt all the supportive care and the counselling we give alongside that. So that's kind of how I see things playing out in 5 years' time. And I really think and I really hope that infection will just become less problematic for people, as will the myeloma, because the myeloma is under control for longer and so the infection risk is naturally lower.
Yeah, no, thank you, Sally. I think the world of antibiotics is changing a lot as well. There's been so much innovation in drug design, but it's notable that the number of new antibiotics becoming available is significantly less than the number of new cancer drugs that seem to become available. There are a number of reasons for that, but I think this is changing. And I think tech is allowing us to look at new ways of giving antibiotics and understanding also how antibiotics are related to this area of increasing and intense debate, the microbiome, all these bugs that live inside our bowel and our mouth and other places. So there's going to be innovation in that space as well. And we'll be able to give different antibiotics for shorter periods of time, which are more personalised. So again, we've talked about, personalised myeloma treatment tailored to genetics or, amount of residual disease. But what about personalized antibiotics? At the moment, it's just, a little bit of, a bit of Domestos here, a bit of, amoxicillin here and other names that a number of our listeners will be very au fait with. But, if we can personalize it, it will make things better. So I think, Sal, what we're saying is that there's a lot of reasons to be positive in this space.
Yeah, definitely. And year on year, the list of positive reasons gets longer and longer, as does, the breakthrough treatments. It all goes really hand in hand, doesn't it? So, yes, myeloma is different and everyone has a different story and a different journey. But in the round, there's a great deal of optimism about the quality of life that our patients will achieve now and in the future. And relating to that is, of course, infections.
Perfect. Sal, as ever, it's been a great chat this morning. Thanks very much, everyone, for listening. And we will see you at the next one.
Absolutely. See you soon, Jam.
Bye.
This has been the Myeloma Minutes. We hope you found this week's pod engaging, interesting, and above all, understandable and genuinely useful. If you enjoyed today's episode, please follow the podcast and share it with anyone who might benefit, from your online support group, your medical team, to friends and family. And as always, if you have questions or topics you'd like us to cover in the future episodes, please do get in touch. You can find us at www.themyelomaminutes.com or email us at themyelomaminutes@gmail.com. And you can find us on social media by searching The Myeloma Minutes on Instagram and Facebook. Many thanks for listening, and we'll see you at the next one.